2013. So this is the latest of the PowerPoints from the new text. The things to be aware of is guidelines for assessing your fetal heart. Okay. Usually, if there's an initial 10 to 20 minutes when the person comes into the labor and delivery area, what happens is you want to make sure that they're truly in labor. Okay. You want to make sure that the baby's heart is in the normal range, and see how the baby is reacting, to contractions, if there's a problem or not. So the guidelines is that the woman comes into labor and delivery, even if she wants a natural birth and doesn't want any machinery or anything else, they'll put her on the monitor for 10 to 20 minutes just to get a baseline on the baby's heart rate. Also want to see if she is contracting and how often. So that's initially, like the triage area or the area that before they truly admit them. Okay. There's a completion of a prenatal and labor risk assessment on all clients. So again, do they have any kind of issues that might cause problems with the birth? Okay. Intermittent auscultation every 30 minutes during active labor. Okay. So with a woman who is low risk, meaning she doesn't have any health issues and the baby's doing okay in utero, they will listen to the baby's heart rate. If this woman decides she doesn't want to be strapped down in bed and she wants to walk around, and really it's better for her that way to walk around and be more mobile while she's in labor so that the baby descends. So anyway, so what will happen is every 30 minutes she's walking around the halls with her husband. 30 minutes they want her back and they just assess her again to listen to the baby's heart and check on her contractions. So that's a woman who low risk, pregnancy. If she's high risk, it's going to be more frequent, so every 15 minutes for a woman who is high risk. So this is really when she starts into active labor. So that's the second phase of labor when she's 4 to 7 centimeters. They'll do this, and then even till she gets into transition, they'll do this. Once she hits, finishes the transition, she gets to the second stage, and again, this is when she's dilated and starting to push the baby. Okay, so second stage, if there's intermittent auscultations every 15 minutes, is more frequent for the low risk woman at this point, and for the woman who is high risk, it's every 5 minutes. Okay, so they will listen more frequently. According to ACOG, and the organization having to do with OB-GYN health, guidelines, how often should the fetal heart rate be assessed for a high-risk woman during the second stage of labor? That's okay. Every 5 minutes. Continuous electronic fetal monitoring uses a machine to produce a continuous tracing of the fetal heart rate. It will produce a graph, and this is a continuous monitoring. So that means she's on, usually she's on Pitocin or she has an epidural. They will continuously monitor her. If she has an epidural, she usually doesn't get a chance to walk around. Okay, so she's not able to. She's sort of knocked from her waist down. Okay, so they will do continuous monitoring on the patient. The objective is to provide information about fetal oxygenation and prevent fetal injury from impaired oxygenation. To detect fetal heart rate changes early before they are prolonged and profound. So they're keeping an eye, looking for like any variable decelerations or late decelerations, or no variability in the baby's heart rate. Okay? And again, this is just showing you, this here, they're showing you the internal pressure. So that criteria for continuous internal monitoring of the fetal heart rate. Again, we talked this last week. She has to have ruptured membranes. The cervix has to be at least 2 centimeters dilated, and the baby should, the presenting part should be low enough so that they can put on the electrode on the baby, and somebody should be skilled in doing it. 4 categories of baseline variability. Now, we talked about this a little bit last week about the baseline variability. Absence is, when we talk about beat to beat, when you're looking at the heart rate of the baby, it should fluctuate, it should not be a straight line. Remember I told you that? Now this variability is looking at the beat to beat or 1 minute of the baby's heart rate. It's different than when we talk about variable decelerations, okay? Variable decelerations has to do with the baby's heart looking like a U, you know, the U, the V, the W. These variables are from, you know, every time the baby's heart beat, should be some movement going on, okay? So if there's no movement going on, that's considered not a good thing. This could be the baby's not getting enough oxygen, okay? If there's a minimal fluctuation range observed at less than 5 beats per minute, that's also something to be concerned about. Moderate, which is normal, fluctuation range from 6 to 25 beats per minute. And then marked fluctuation is greater than that. So you really want to see that it's beat to beat to beat, you know, in a moderate fashion. Okay. Now this is what's new. Okay. This is what you will have this in your slides, and then I just handed that sheet of paper out to you. So what they've done since I think it's 2011, they have decided to use categories instead of saying the person's having late decelerations or early decelerations. They are actually put into categories now. So if the doctor or midwife, somebody comes and says, what's going on with the fetal heart, if it's category 1, that's good. Okay, category 1 is considered good, meaning there is variability. You know, time the baby's heart beats, fluctuates. There might be some early decelerations, which is fine. Remember, early is good. The early food class is good. Being late is not. So all that is considered category 1, all the good stuff. Category 2 is what I call iffy. It's a little iffy there, and you have to keep an eye on it. What happens is, you see the fetal heart may be above 160. Bradycardia, the heart beat below 110. There's some absence of baseline variability, and there's again minimum or marked variability. You don't need too much, too little, and current late decelerations. So all this in category 2, it says indeterminate. It's sort of something you have to keep an eye on. Okay, and then category 3 is predictive of abnormal acid-base status. So that's the late decelerations. That's the variable decelerations. Okay, and just abnormal patterns. So when somebody says they're category 2, that means you have to sort of keep an eye on the patient. Category 3, they might have to act real quickly and deliver the baby. You see here on the second page that this is look around the paper I gave you. It shows the different types of decelerations. Okay. And the first one being early deceleration, and you see from the baby's head, so it's from head compression. Then you have variable, which you see are very distinct looking lines, like there's a V at the end there. And that's from cord compression. And then the late decelerations, when there's a peak of contraction, then you see the heart rate starting to go down. When the baby's not getting enough oxygen, and that's from the uroplacental insufficiency. Okay. If you take a look at the next page, on that handout, it says interventions for category 3. And again, it's right here for you to see. So category 3, again, is a late decelerations, variable. Notify the healthcare provider about the pattern. Okay, obtain further orders. Reduce or discontinue oxytocin or any other agent that might be causing the woman to contract. Okay. Turn the woman on her left side or right lateral side or knee chest or hands and knees to increase placental perfusion. Because again, it could be the placenta's not being perfused, so there's not enough oxygen. Administer O2 via face mask is really good for doing. To increase oxygen in the fetus. Increase the IV rate to intravascular volume, correcting hypotension, separate women from the other underlying causes, provide reassurance that interventions are to affect pattern change, modify pushing to the second stage to improve oxygenation, document any and all interventions and any changes in the fetal heart rate, and prepare for a quick delivery if this is not corrected in 30 minutes. So these are all the things they will do for the category 3. Okay? Everybody comfortable with that? Okay. And then we have, I'm going to go on to the other pages from the other slides. Okay, so that's why I wanted to show you these slides for that information, because that's new to this book. I put her up a ring last night.
She won a championship? She won a championship.
Yeah, I think he's so happy, so thrilled. But it turns out they've only been dating 9 months.
Daddy.
It was,
She won a championship.
I guess it was like May 11th or June 11th they started dating, so yesterday was the 11th. So I guess it's like sort of doing that way.
Oh, where's mine?
How'd she ask him? How'd he ask her? Woo!
Master's degree is a physicist. He's a physicist. But he's an engineer. You know, that the company she works at.
How did you propose?
He got down on his knee.
Oh, sick.
And said, you know, just said, you know, he wants to spend the rest of, you know, his life.
You know,
I said, I hope you
I'm gonna get down on my knee and be like,
you know.
I know you are. I know it. That's not even a joke.
oh. She'd be like, oh.
It's not sad. It's not sad.
And then she looks at it and she's like, oh.
She was trying
I'd be like, oh, oh, oh.
Dude, what the fuck?
Yo, why there no internet connection here though? Can everyone please stop trying to download the PowerPoints? That means you download it first. I'm trying to record the lecture. What? What?
What?
The lecture.
I don't have any what?
Easy, Neo, the remix, Ayo.
Okay, this again is showing you the different patterns of what we just talked about.
What's LSD? Favorite delivery.
We talked about
Love and what?
quite a bit of it already, but you can see.
Do you like drugs? You like that song?
No, I actually don't.
You don't like Miguel? Do you like How Many Drinks?
Talk about
How Many Drinks?
pain.
What song is that?
I don't know. How about The Thrill?
I don't like it.
Pain management.
You're so much better than The Weeknd.
I did slide you that you have more.
Fucking Weeknd is
slides, So we know that people can have natural birth if they choose to. And again, some people choose not to and they prefer to have medication during labor. So drugs that they might use in labor and delivery are systemic drugs, meaning it goes into your system, either IV.
Hold my hand.
Usually it's IV at that point. It could be morphine, Gamoral, Stadol, which is usually much more popular than the other first two, Stadol. Valium, Versed, these are all systemic analgesics. Often they'll give Visceral or Phenergan with these drugs, like you would always do like Gamoral, put some Visceral in there, or you put some Phenergan in it. And what that does is it enhances the narcotic, but it also will stop any nausea the woman might be experiencing and any itching that she, some side effects that she might get from not having the anesthesia or analgesia.
You walk
There's
there.
also local anesthesia. They reduce lidocaine, okay? Just like, no pain when you go to the dentist.
No. I tried
So
downloading
they'll-
it, and
what they'll do is they'll
there's a free version.
do
I would have
local
only only 5 minutes.
They either do it so that areas that are being, okay, so what they're doing here is like little and what they are numbing is this
Look at that
particular
vagina.
area. Okay, so the pudendal goes into the pudendal nerve. Okay, so
Pudendal.
the needle
Pudendal.
will go to the pudendal nerve.
Pudendal.
One of the places they look for is
Pudendal.
the medial spine in the
Pudendal.
department is the pudendal nerve. And that is something that they do usually when the woman is either pushing the baby out or when maybe they'll do an episiotomy on the woman, which is the cutting. Yeah. So they'll numb that area so she doesn't feel it. But it doesn't stop her from having painful contraction. It just numbs this area for perhaps the baby coming out and then doing maybe an episiotomy. Okay. So that's called the pudendal. That's a local one. Also, they could just do regular local anesthesia with a lidocaine if the woman, let's say her epidural wore off or something, they would just put the lidocaine in the area that they might need to do the episiotomy, the cutting, okay? So she could just have, not going all the way into the pudendal nerve, but going into just this local skin so that they can, you know, if she needs to be, you know, cut for the episiotomy, she would feel that. Regional epidurals, usual anesthesia is epidural block, walking epidural. No one has ever seen anybody, but again, I always tell people, look, find out what hospitals you're at. Walking epidurals I've yet to see, meaning that they have an epidural that perhaps isn't as, I can't even tell you what, intense, so they're able to walk around. I've yet to ever see that, although it's in the textbook saying there is, okay. For the most part, usually if a person has an epidural, they are, the pain is usually from the fundus of the uterus down to the legs. It's not felt, so you don't feel any pain, okay. And it also, your legs are numb, you can't really get up and walk, okay. So that's something to be aware of. The spinal block is usually done only for cesarean sections. So they're not done for people who are having, you know, vaginal delivery. And then there's general anesthesia, which is really done a lot of times in emergency situations, or people who have contraindications where they can't have a spinal, or they can't have a epidural. Maybe they have a bleeding disorder or an infection, or they could have scoliosis, so they can't get a spinal or an epidural. One time we went in last year, probably traditional students, and we get to L&D, and this woman is coming out from the C-section room being ambu bagged, right? They were resuscitating her, and I said, what the heck happened? The woman had scoliosis, and they gave her a spinal.
Oh
and
my God.
It stopped I didn't even know you don't do that. I don't do the anesthesiologist was. But they had to bring her up to the intensive care unit. She was revived, but the point was that when you have certain problems, you're not allowed to have epidurals or spinals. Having something abnormal in your back or in your spine is one of them. Bleeding disorder is another one. Infections is another one. You know, so just know that. Okay. Nearly all drugs pass through the placenta and affect the infant. Okay. The Narcan, which we're going to use for it, Narcan is medication that can be given to reverse the effects on the mother and on the baby. The problem with the mother getting, let's say, morphine, Demerol, Stadol, Valium versus any of those systemic analgesics prior to delivery, if she's going to deliver within 2 hours, they don't want to give her any of those narcotics because it can affect the baby's respiratory rate and it can depress the respirations of the baby. Okay, so if that happens and they give her that, let's say, Demerol or morphine, and all of a sudden the labor speeds up and the baby's born an hour later, they'll try to give the baby the Narcan, okay, reverses the effects of the narcotic, or they give it to the mother and to the baby, and again, it will reverse the effects of that medication. So if you reverse those effects, the mom's going to start feeling pain again. Okay, but the baby, the baby should be able to, breathe okay without being depressed. Okay, so what do I have here? Review pages 380 to 382 in textbook, and that's the second edition. And then no drug guide on 14.1. I believe that table 14.1 is in the new book too. Okay. Pain management, the non-pharmacological, again, it's natural childbirth, avoiding all drugs, prepared childbirth classes, moms, graduate method. These are just different types of things that they can do to try to have a natural childbirth. A labor coach, as like a doula, they provide motivation to endure the pain. They'll help the patient with relaxation techniques and breathing techniques. So again, as you can see all the different things that, this is like a person who's sort of strapped in bed. They don't want that. They want the patient to be able to move, walk through the halls, do this. We have this woman who's pushing on this one's sacral area. Maybe the baby's in a posterior position. If the baby's head is posterior, she's going to feel more pain and her back is going to be longer labor. Okay, this is in one of those foods or whatever. Interventions by the nurse. Encourage partner participation. Keep couple up to date on progress. Provide ice chips as needed. Maintain IV rate and input. Provide comfort measures, again, maybe rubbing her back, or, they have the oils that they use on the woman to relax her. Assist with breathing techniques, change that blue pad and bed linens as needed, because her membranes are ruptured. Every time she contracts, more fluid will come out. So you sort of want to keep everything nice and clean, so, the baby when it comes out too. Keep the perineal area dry and clean, so that's something, again. Woman might have an epidural, might not feel it, but you know that. Okay, stage 2, fully dilated delivery of baby. Okay, and pushing and delivery, 10 centimeters fully dilated through birth is stage 2. Some people will use squatting, okay? They have a squatting bar you can hold on to. Yeah, you can hold on to it. And again, gravity allows there's more open space for the baby to be able to come down. Okay, so that's one way she can do it. The other way, you can have her legs right up there, try to push the baby out. This lady looks like she's on her side somehow. It's not beautiful. I mean, it's like, it's beautiful to birth, but before you have the baby, it's not a beautiful thing to say. Yeah. This woman is, she's actually screaming in joy. No, doesn't look that way. No. But anyway, so, yes. Now, would you want all your kids in to watch that?
That's hella painful.
No.
Who the hell keeps getting text
But
messages?
anyway, so, see, she's delivering her baby.
I don't mind looking at it.
Look like
I don't mind it.
Position, to be honest with you. My legs like to be falling asleep. I can't feel my legs. But anyway, so this is the baby's head is crowning.
She's like, it's a bride!
This is when it's sitting with the baby. This is it coming out. Okay. And then this is her, this is the woman's tush. Yeah. Oh, okay. And she might have a bowel movement, but she's having a big baby. So that's why people will say they feel like having a bowel movement, but they're having a baby. I guess whatever way works, When you give birth to that baby,
I didn't know you could do it like that.
You know what I'm saying? Yeah.
I pissed at my mom if she gave birth to me like that.
Huh?
I'll be mad at my mom if she
It's
gave
hard
birth
to
to me
say. It looks like the baby's head looks pretty good. Like, it doesn't look like she's going to tear. And then there must be somebody like a midwife, because no one's doing an anesthesiology, which would be right there. Okay. The third stage is birth through delivery of the placenta. The placenta is examined for intactness. If part of the placenta is retained in the uterus, it can cause a postpartum hemorrhage. So they take a look at the placenta. Okay, it's pretty big. They try to make sure it looks all intact. Okay, And the way that the placenta comes out, there's a couple of different things that you might hear. If the placenta comes out looking like this part here, it means that this part was facing the mother's uterus. Okay?
Yeah.
So they call it dirty Duncan, or actually
Oh, yeah.
it's called Duncan mechanism. If the placenta comes out like this side coming out first is
What's the
called
other one?
Duncan mechanism. If it comes out shiny, they call it shiny Schultz.
Shiny Schultz.
I know. So the baby's, so if it faces the baby side of the placenta, it's the shiny, pretty side. The dirty Duncan side is the one that faces the mother and sort of looks dirtier. Okay, so that's
Sort of.
two different ways that the placenta can come out. Does it make a difference? Probably not. Schultz and Duncan want something on their names on something, and they choose the cooking names on this. Well, there might be a question having to do with that. The one that faces the mother is the dirty Duncan, and the pretty shiny one faces the cute shiny baby. Okay. So blood loss for vaginal delivery is approximately 500 mLs. You'll see that on the patient's chart. The doctor will write down approximate, blood loss. He always seems to write 500, 400. I don't know if they actually measure it, but they always write about that. For a C-section, it's more. It's about 1,000 mLs of blood loss. Okay. There can be different. There can be lacerations if the woman delivers the baby too quickly, or the baby's too big. They can have lacerations, one first degree to the fourth degree laceration, and one is just skin deep. One goes a little bit further, and the fourth degree actually rips to the rectum. Okay. Person who has a fourth degree laceration. The first degree laceration extends to the skin, second degree laceration extends to the muscle, third degree laceration continues through the anal sphincter, and the fourth one involves the rectal wall. Okay. So a person who has a third or fourth degree laceration, they cannot have a suppository. It makes sense, right? There's a big tear there, so they cannot have a suppository or enema. Okay. This is showing you the different types of
It's gonna hurt.
episiotomies that they can have. Okay, this is called a midline episiotomy, and this is called a lateral episiotomy. See, goes to lateral, this is midline. The thing about the midline, it could actually tear down to the rectum, so sometimes we don't use that midline one. The baby's head's really big, and they have this, and it tears. And then this is a medial lateral one that they have. Recovery in stage 4. This is where the bottom of the baby, she has her shirt is off and the baby's on her. That's what they call skin to skin. So the baby stays warm, being skin to skin with the mother. Okay, because the baby can lose heat. So that's something that they can do after the baby's born, so that the baby doesn't lose heat. The mother's blood pressure after she delivers, usually it's pretty stable. Where it was before she got pregnant. Her pulse might go down a little bit. She might have maybe a little bradycardia afterwards. Her temperature is a possibility that she has a very low-lying fever, maybe 100.3 or 99 degrees, because she's dehydrated. Okay, she might have been breathing and dehydrated, so she could have a slight increase in her temperature. Her fundus, you're going to assess. Her fundus should be firm and midline. Usually when the baby first comes out, the fundus actually drops between the symphysis pubis and the umbilicus. So because everything's being pulled out, so the fundus sort of goes down and then bounces back up. The woman could be shaking. A lot of times they can't control the shaking. They're not sure exactly why that is. But a lot of times they're just very shaky and cold. You put a warm blanket on them. They're hungry and thirsty, again, because of the fact they haven't had anything for at least 24 hours. And their bladder, you want to assess that because sometimes they don't feel the urge to urinate, and the bladder might start to get full. I don't see the stages of labor. Stage 2, baby time, push, push, push. I'm going to do the, yeah. Okay. So if you read this is really cute. Okay. And then they're showing like here, labor duration, take a look at the first birth of purple. Okay, so the latent phase, which goes from 2 labors to 3 centimeters, could actually be, maybe 8 hours or 9 hours long, okay, for the person who's having the first baby, where it's like half of that for the person who's had babies before. Active phase, again, this could be about 3 or 4 hours for the woman having her first baby, half of that for the person who had babies before, and then transition, again, this could be an hour or 2, and it's much quicker than somebody who's had a baby before. Okay. Culture and early culture. Some cultures will allow the woman to vocalize. Okay, Hispanic cultures will let that happen. Some cultures, like some Asian cultures, the Chinese, different Asian people, are not allowed to vocalize. They're just supposed to keep internalize their, how they're feeling if they're in pain. Again, modesty. You can see some of those pictures. There wasn't a lot of modesty going on, but there are some cultures. Somebody who might be a Hasidic Jew, they really don't want. They usually don't want students in with them to the face, but a lot of times they are very modest. Also, Muslim women also they don't like having a male attendant, so they want a female doctor and a female nurse in with them, and they too are very modest. Okay? And then again, with the birth and culture, a preference of a birth attendant, meaning your doula or maybe the mother or mother or somebody there. Presence of a husband, and most cultures nowadays it seems as though the husbands are there, even though in the past they're all in the waiting room because I'm Joey. So a lot of the cultures will have to have them there. And the person who is Hasidic, Jewish, what happens is they're not allowed to touch the woman because she is bleeding. So she has blood. So you might see him in there with the mom, and you might think, why isn't he, having her back or hugging her or anything like that? Because he can't touch her. It's a religious reason. They cannot touch the woman because she has blood coming out of her. So, sometimes you see that and you're like, why isn't he? That's for George. Some cultures of C-section.
Acidic.
I know I had a student a number of years ago.
They're basic
saying
Jews
that
too.
She's from Haiti, and she ended up having a C-section, and her parents were very disappointed that she had a C-section because in the culture, you're a weak woman if you have a C-section as opposed to having a vaginal birth. And then any kind of specific cultural requests that they might have, as I said, the Koreans like to have their seaweed soup after they deliver. Some cultures feel as though colostrum, the first milk that comes out for the first couple of days from the mom's breast, they consider dirty. So the patient may not want to breastfeed the first couple of days because of the fact that the culture believes that first milk is dirty. So she might go home and start feeding the baby when her real milk comes in. So that's pretty something cultural that you might see. Okay. The process of birth, cesarean sections, why do they use cesarean sections? Malpresentation. Okay, so you can see here, this baby's a shoulder presentation, so it's not going to be easy to get this baby out unless it has a C-section. Breech babies, they usually automatically will do a C-section on them. Footling breech also, it's hanging out, they will usually just take the baby by cesarean section. Fetal size, if the baby is, a lot of times you'll see on the chart, you'll see macrosomia, reason for C-section, macrosomia. Macro being big, somia meaning body, so the baby is large, okay? Maybe the baby's 9 or 10 pounds, and this is the woman's first baby, and she will not be able to have a baby vaginally, okay? Poor progress during labor. You'll see sometimes it will say failure to progress, so the FTP, why she had a C-section, failure to progress. For some reason, maybe the baby's too big to actually maneuver through the birth canal. Fetal distress, and that's with the late decelerations or variable decelerations that they might want to get the baby out quicker. Health and age concerns, again, the health of the baby and the age of the baby. If they want to get the baby out really quickly and there's maybe some kind of problem with the baby, they maybe don't want to put the baby through the stress of labor, so they'll get the baby out by section. And then maternal risk factors. Different things that she can have a placenta could be covering the exit, the os, and they can't come out that way. Some women I've heard had varicose veins of their vagina, and it's so painful they have to have a C-section. If the woman has herpes, active herpes, she has to have a C-section, so she's active at the time of delivery. So that's some of the things that would that person have a cesarean. The term VBAC, how many people have ever heard of VBAC before? Yeah, so that's vaginal birth after a cesarean section. Okay, so some women will try to have a vaginal birth after their first or second baby was by C-section. What they'll do is usually they'll do we'll try a little bit of trying of the VBAC, a trial of putting her on Pitocin. They will have to have an internal monitor on her uterus, okay? Because of the fact that she's had incisions in her uterus from having a C-section, she's at higher risk for rupturing her uterus, okay? So they keep a very close eye on her contractions, so they like to have an internal monitor for her, so it's more exact. Some doctors just don't even, even deal with it. The insurance company used to say we want to see this some kind of trial of VBAC as opposed to a C-section right off the bat. And then they turned around and said no, seeing that there were some ruptures of the uterus, and causing women to bleed or die or never have a baby again. They said, okay, you can keep doing your C-section. Some women want to have another C-section. This way, what happens is they say, all right, I have a 3-year-old at home. I can plan the date of my C-section, get my mother here from Las Vegas or wherever, and have her take care of my child. So it's all set up for time, easy. You know when you're going to have a baby. And some people don't want to even go through labor, So the process of birth, some complications. Anoxia is loss of oxygen immediately surrounding birth, and this can cause the baby to have cerebral palsy or mental retardation. Okay, you don't want to see that. And this stuff that we're seeing here, we're going to talk about towards the end of the semester. There's certain things that can happen with the placenta, an abruption. The baby doesn't get enough oxygen. That's an abruption here. Uterine rupture, again, that's showing the uterus ruptured. See how that looks? Okay, again, that can be, it's usually from Pitocin. A lot of it's just from Pitocin, giving too much, high amount of Pitocin, and not monitoring it really well. The uterus can rupture. Okay. Again, the baby could die, the mother could die. It's just not a good thing to see. Let's see, other complications, shoulder dystocia. Okay, so a lot of times the biggest part of the baby is the shoulder and the shoulder pads, and what will happen is the baby's head will come out, and then the shoulder's sort of stuck, and they have to manipulate the baby around a little bit to get the shoulder out, and it can cause the baby to have like a little a palsy, meaning there's a little paralysis at first, like a brachial palsy that the baby could have after it comes out, or the baby can have a clavicle fracture. Okay? That's the most common fracture in an infant below the age of 1 is a clavicle fracture. That could happen. Okay? Other things that we could see is the umbilical cord prolapse or compression. Okay, so here, let's see, the baby's head is not totally engaged yet, and they rupture the membranes, or membranes just rupture on their own, and the cord comes pouring out of the vagina right here. Okay? And what happens is, when the baby starts to descend, and the baby's head will lie on the umbilical cord, and the baby gets no oxygen, the baby can die. Okay? I'll tell the story. I know Karen Jasko told you, but I'm going to tell the story. It happened a few years ago, one time ago, when I first got out of school. This woman had, she was being monitored and all that stuff, and her membranes ruptured. So usually, when I tell the students, what do you have to look at? You know the taco thing we talked about last week as far as membranes being ruptured. But the other thing about it is you want to look at the fetal part when the membranes rupture, that bag of water ruptures, because of something looking like that. Okay, the membranes rupture, and you want to look at the fetal part because you're going to see, because it's cord compression, those variable decelerations that we talked about, with a V or a W or a Y or whatever, or U. And what happened was I saw these really bad variable decelerations. I looked down at her vaginal area and the cord's hanging out. Okay? So you call an emergency because, again, the thing's not going to get oxygen when the head presses against it. And so what I had to do is get my glove on, put my hand into the woman's vagina, and take the baby's head and push it off of the cord. Okay? Not touch the cord. Because if I'm touching the cord, I'm squishing it too, not getting oxygen. I had to get the head of the baby off of the umbilical cord, and we brought her in for a stat C-section because if the baby's head continued on the cord, the baby would be dead or brain damage. So that could be an emergency. So anytime the membranes rupture, one of the first things you're going to look at is a fetal heart, because if that cord is compressed like that or prolapsed like that, the baby could die. Okay, so you want to look and see if there's any kind of late or variable deceleration to that. Other things, placental dysfunction. Sometimes the placenta gets what they call infarcts in it, and meaning that there's areas that are not working as well, so the baby may not get enough oxygen. That happens more towards 42 weeks or so in the pregnancy when the placenta is getting a little older. And then something that you don't see that often, amniotic band syndrome, okay? And this is, how do they put it this way? I always think that you have like two sacs around the baby, okay? And when the sacs are developing, the baby's hand might be by one of the sacs, okay? And that sac will enclose around the hand, and the hand will look like this when it comes out, or the foot will look like this when it comes out. Because the little bands around that. I only saw it once in my life, really, to be honest with you. I saw it on hand. But, so that would be, again, depending on how much was involved, it could be the baby didn't have enough circulation there, maybe, it's not really developing muscle. So, this is something you don't see that much of. Thank you. What was that? Well, it depends on it. It really depends. I mean, I had one woman whose baby's hand was, wrapped around the sac, and the hand never developed. And the baby had no ability to move the hand. I don't know what happened then. I got the slide. I saw her. But again, depending on how much injury was involved, the baby may not be able to use the foot. The muscle may not develop, or they might try to do physical therapy on the baby. Induction of labor. This is so induction of labor. This is when the woman is going to be induced into labor, meaning, let's say she's 41 weeks, 42 weeks, she still hasn't gotten into labor yet, they will induce her, okay? Or meaning that the placenta's starting to get old, and they want to make sure that the baby's going to be okay, so they'll bring her in and induce her, okay? Evaluate the fetus and maternal status before, there's a consideration before induction. You want to see what the fetal size is. You want to know the position of the fetus and gestational age of the fetus. Again, if the baby is in breech position, they're not going to give her Pitocin to induce labor, right? Because it's breech. If the woman has a placenta previa where the placenta is blocking the exit, the os, they can't induce her because she can hemorrhage with that. So they have to evaluate the mother, the baby size, the age of the baby. Evaluate for fetal well-being. You want to see that on the monitor, when they put the mom on the monitor, that the fetal heart rate increases when the baby moves. That's well-being. That means the baby's doing well. When the baby moves, the heart rate will increase and then go back down to baseline. But that is something that they, they look for before they induce. The nitrazine paper or Fern test to establish status of membrane. We talked about that last week. It's a yellow piece of paper. They dip into fluid. It should turn blue. And that means it's amniotic fluid. The Fern test is that, remember I told you put it on a slide and let the fluid dry out and look under a microscope. It should look like so that means that it's truly amniotic fluid. Complete blood count and urine analysis to make sure there's no infection going on. Vaginal exams to evaluate the cervix, that see that the cervix is able to be induced. Okay, so accurate pregnancy gestation beforehand, and then they want to look for what they call cervical ripeness. And it almost sounds like a fruit, right? To be ripe. So what they're looking for, they use something called the Bishop's score system, and that's in one of the first original chapter 14 that I gave you guys. It's not, I didn't look at the time, this person's stuff. It has something called a Bishop score. Okay, I think it's like 97. How many slides are there? Like 97 slides or something like that. You'll see one slide when we talk about induction in your, the PowerPoint where they have the Bishop score there. Okay. For some reason I don't know why it's not here. Okay. So what they'll do is they'll decide if the cervix is ripe enough. And what they're looking for is the position that the cervix is. They want it more anteriorly positioned, so that they consider that more inducible. That the cervix is soft, that's considered being, being inducible. And a little bit dilated, that's considered, that she's able to be induced. So they have a scoring system. And if the cervix is anterior, soft, a little bit dilated, they will put her on pitocin to induce her. Okay. See, these are some of the reasons why people will be induced: diabetes, renal disease, high blood pressure, ruptured membranes prematurely, history of a fast delivery, precipitously majorities, quick delivery. I noticed we would say termination of pregnancy after 39 weeks. I can see what top means. Don't know what top means. Top after 39 weeks. All right. It can't be termination of pregnancy. But anyway, so indications for induction of the fetus: if there is an infection in the sacs that surround the baby. One sac is the chorion, the other is the amnion. So it would be chorioamnionitis. Okay. That's an infection in the sacs. Post-term gestation is the most common reason, so they're usually past 40, 42 weeks. Mild abruption with no fetal distress. That means that the placenta is pulling away from the wall, a slight bit. If there is a uterine fetal demise, it will induce the woman to have her go through labor. Usually they'll give her a lot of drugs so she doesn't feel anything. They prefer having her go through labor only because C-section, she could have scarring, infections, and all that. That can cause her maybe not to ever have a baby again. So it's safer to have the woman induced, and they just drug her up basically so that she doesn't feel anything. And then if the baby has intrauterine growth restriction, meaning the baby's too small for its age, there might be something going on with the placenta not perfusing to the baby enough oxygen. And then the contraindication, client refusal, something called cephalopelvic disproportion, CPD, means the baby's head's cephalic, cephalop, okay? The head is too big and the pelvis is too small, so it's called cephalopelvic disproportion, CPD. Okay? So that could be a reason why not to induce. The baby doesn't can go down any further. Any condition is limiting or spontaneous labor or vaginal birth. Placenta previa, as I said, that's when the placenta is blocking the exit, so placenta is there and the baby can't get through. A transverse slide when baby's lying, of course, like that. A previous classic uterine incision and active herpes. So a previous classic uterine incision, usually if you see the uterus, it's usually when a woman has her baby. Let's see this. The woman has her baby, her daddy. That's her belly button there. In a regular C-section, they will usually do an incision low down, okay, right across. A classic uterine incision is done like this. Yeah, up and down, like that. And why they do that, if the baby's particularly large or an emergency, because that's easier to get the baby out doing this classic incisions, a faster incision to make. So they'll do that. But you don't see that anymore. Really, used to be years ago, you used to see this classic incision, but I don't see it really. I haven't seen one in years. But anyway, the reason why you don't want to induce her, because look at the difference. If this is her uterus here, uterus, beautiful. Okay, that's her uterus. This incision, the lower incision here, the one you see all the time now, is only bothering this much of the uterus. A classic incision takes up just about the whole uterus. So she's at real high risk for her uterus to rupture because of that kind of incision, okay? Because it takes up, look how much it takes up of the whole uterus here, and that might weaken with contractions, where this type over here doesn't take up as much, so she could have tried to be induced the second time around, okay? And then active herpes. Induction of labor, different mechanisms for this. You could do, they used to do nipple stimulation, okay? So I remember somebody saying, I'm overdue or I'm overdue. I said, stimulate the nipples. Stimulating the nipples causes Pitocin to be released from the brain, okay? So Pitocin is like the induction of labor. You can have Pitocin to get her going. Nipple stimulation causes Pitocin to occur, so she can contract from that. Okay. Mechanical reasons how they can do it is sometimes they go in and they try to strip the cervix, meaning they are trying to, when they go in and try to strip the cervix, they take out some of the mucus plug that's in there, and that sometimes causes prostaglandins to start working, which causes contractions also. They will also do the artificial rupture of the membranes, okay? And they use these two items here, which can cause the uterus to contract, and then Pitocin. Okay. These two items, you usually see Cervidil. What that is, Cervidil is something that they use. They'll say the woman's like 40, 41 weeks, they want to deliver her. They bring her in the night before the labor and delivery, okay? Put her on the monitor, get her set up, and they will put Cervidil into her cervix, okay? It could be a gel. But a gel they put into the cervix, and what that does, the Cervidil, it actually softens the uterus, and so that she is ripe and ready to get induced the next day with Pitocin. The Cervidil can actually make a woman go into labor too, but that's, Cytotec is sort of off-label, unstable, basically. They don't really like to use it as much. So usually if a woman has a intrauterine fetal demise, they'll use this. But it's really unstable. And it's actually like an antacid to begin with. It's not really used for that. And then we have Pitocin. So complications with Pitocin, again, this is on your first quiz this week, right? So I see epidural and all that. Complications, water intoxication from Pitocin. So you want to check that out. Fetal distress if the contractions are too close together. Uterine rupture possibility. After she delivers, she might have uterine atony, which means no tone to the uterus, so she could hemorrhage. And then the other thing would be hypotension. Okay, just like the epidural, side effect, hypotension, right? Everybody knows that. It's on every single test. Okay. Hypotension. And then nursing care with the use of oxytocin, provide intubation, noted contraindications for ensure written consent. You get a baseline of the fetal heart, you want to get reassuring. Need a baseline assessment of human activity and internal vital signs. Assess internal INO baseline throughout labor. Watch for signs of water and toxicity. Means that she's not urinating. Okay, she's retaining fluid. Assess and document prior to dose increase. Every time you increase the dose, you're going to, right before you increase, you want to get the uterine activity, fetal heart rate, variability, and reactive. You want to, this is the last thing. Anytime before you do anything, you want to get the uterus, see how it's doing, the fetal heart rate, the mother's vital signs, and all that. Okay. And then you have the process of birth. Take it out. Baby coming out there. They use something called APGAR score. Okay. This is assessing the newborn at birth.
Take that shit out.
Within the first 5 minutes. I mean, first minute of birth, and then 5 minutes later. So this is what they're looking for. What they want to see is a score 8 to 10 is good. Okay. So they want to see fetal heart rate should be over 100. Okay. Respiratory effort, usually that means the baby's crying. Okay. Muscle tone, active movement, reflex irritability, that the baby is like crying and like able to react and cry, and then the color all pink. Okay. So usually you'll see a score of 9, and that's usually because the baby has what they call acrocyanosis, where their hands and feet are blue. Okay. So not all pink. So sometimes you'll see a score of 9. So that's how they score the baby. Any questions? We take a break?
Yes.
Okay.
Let me kill Eduardo real quick.
Take 15, 20 minutes. It's 2 o'clock. 15 minutes after 2. Okay.